Hi, my name is Dr. Gareth Weston, a practising IVF specialist in Melbourne with over 20 years' experience. Welcome to my podcast. In this episode, we're going to talk about one of the most common questions that I get asked by patients. Doctor, how many eggs should I be expecting in the IVF cycle? It surprises me how many patients have no idea how many eggs they should be aiming for in an IVF cycle. And it surprises me also how many patients come from other doctors not having had any expectations set as to how many eggs is an ideal number to get in an IVF cycle. There are a number of factors which will influence the number of eggs that you get in a cycle. Some of those factors are factors you bring with you, patient factors. These are factors which you may not be able to change. But some of the other factors are directly related to the way that the cycle is managed. These are the responsibility of your clinician or your doctor, and these can be controlled. We're going to go through those factors one by one in this podcast. So let's start with the patient factors. These are the factors about you which will influence the number of eggs that are able to be achieved with an IVF cycle. The first and probably the most important factor in the number of eggs you're going to get is your age. As a woman gets older, the number of eggs within her ovaries declines, not only in the number of eggs, but also the quality of the eggs. So this means that as you get older, not only are the number of eggs on average that we're likely to achieve going to drop, but the number of embryos that we're able to make from those eggs when we fertilise them with sperm is going to be less per egg. So less eggs and lower quality eggs. The second patient factor is the egg reserve. This is the concept of the number of eggs that you have within the pool of eggs that remain in your ovaries. Now this is partly dependent on age, but you can have a younger woman who has a low egg reserve, so it's not strictly related to age. There are two ways that we can determine your egg reserve. One is a blood test called the anti-Müllerian hormone, or AMH, sometimes called the egg timer test. This is a blood test which gives us a hormone level that is proportionate to the number of eggs remaining in your ovaries. Most of my patients will have an anti-Müllerian hormone so we can have an idea of the number of eggs in their remaining pool. And that will give us a bit of an idea of the number of eggs we're likely to be able to achieve with an IVF cycle. The other way we can determine the egg reserve is with an ultrasound, counting the number of small follicles on each of the ovaries, called the basal antral follicle count. If the basal antral follicle count is very low, for example, less than 8, we might expect a lower number of eggs to be able to be achieved with the IVF cycle. The third broad patient factor is if you have gynecological conditions which will affect the number of eggs that we're likely to achieve. Now, this can work in both directions. If you have polycystic ovarian syndrome, for example, we're going to expect larger egg numbers. If you have endometriosis, on the other hand, another very common benign gynecological condition, we're going to expect lower number of eggs. Next, we'll talk about the cycle management factors. These are the things that are within the control of your doctor when they're planning your treatment cycle and will directly impact on the number of eggs that are achieved with the cycle. The first, and probably the most important, is the dose of follicle-stimulating hormone. This is the injection which you take daily for 10 to 14 days in order to stimulate your ovaries to produce eggs. We tend to start with a young woman under the age of 35 with no gynecological conditions and a normal egg reserve with a dose of 150 units. But based upon patient factors, we may adjust that up or down to try to aim for the right number of eggs. Some doctors If they find that with ultrasounds there is a low number of eggs developing, we'll try to rescue the cycle mid-treatment by increasing the dose halfway through the cycle. I believe that this is very bad practice because the follicles have already been recruited in the first half of the cycle. My preference is, if you don't have the dose right, cancel the cycle and restart again the next month with a higher dose. Not only is the dose of FSH important, but there are some types of FSH drugs which act very differently. So most of them are just different brands with very little difference between them, but there are two types of FSH which are different to standard FSH. One is the long-acting Elonva medication. This is an FSH drug which has been modified so that it has sustained stimulation of the ovaries for a full week rather than a daily dose. The second is an FSH-LH combination. These are the two different hormones which your brain releases to act on the ovary. The second cycle management issue is the protocol type. Most doctors use a standard antagonist protocol because it has low side effects and a lower risk of ovarian hyperstimulation syndrome. But there are other types using an agonist which have a higher risk of ovarian hyperstimulation syndrome, a condition where you get an over-response from the drug, which sometimes are warranted in order to get a larger number of eggs. The third part of the cycle management is the ovulation trigger. The type of ovulation trigger, whether it is a heavy trigger or a lighter trigger, and the dose of the trigger. Generally, the higher the dose and the stronger the trigger, the greater the egg numbers you're going to get, but the higher the risk of ovarian hyperstimulation syndrome. We will go into ovarian hyperstimulation syndrome in detail in a later podcast, but we don't have time in this podcast as it's not directly related to this topic. The third cycle management issue is whether we need to add adjuvant treatments such as antioxidants, growth factors, to try to improve the egg survival. And the final aspect of cycle management is the physical technique of the egg collection itself. Sometimes patients have very difficult to access ovaries and will require experienced clinicians capable of doing egg collection from an abdominal approach rather than the standard vaginal approach. Either a laparoscopic egg collection, sometimes we need to push on the abdomen during the procedure so that we move the ovary into a position where it can be accessed. Sometimes we need to put the needle into the ovary through the uterus, a transmyometrial approach, which some practitioners may be comfortable to do, others may not be comfortable to do. The other aspect of the physical collection of the eggs is whether you use a single lumen needle, which just drains the follicle, or whether you're concerned that you have eggs that might be sticking to the side walls of the follicle, in which case you will use a flushing catheter that not just drains the follicle, but also introduces a flush to dislodge and collect eggs that are otherwise sticking to the side of the follicle. So that ends the cycle management factors with regards to egg number. So we've gone through the factors that influence the number of eggs that you should be aiming for in an IVF cycle. But how many eggs should we be aiming for? This was the very first question we started with at the start of the podcast. I would tell my patients you should be aiming for between 8 and 15 eggs from an egg collection. Why should we be aiming for 8 to 15 and not 20 to 30? It's very simple. If you're achieving more than 15 eggs, you may have the chance to make more embryos, but you have an increased risk of ovarian hyperstimulation syndrome. This can be very debilitating, although temporary, and lead to you being in hospital for weeks with the most severe cases. So we want to try to avoid ovarian hyperstimulation syndrome. On the other hand, if we're getting less than 8 eggs, the number of eggs we have to create embryos is lower, and therefore the number of embryos we're going to get is lower. This is going to reduce the chance that you will achieve a pregnancy once you have used all of the embryos from the cycle. We call this the cumulative pregnancy rate. So 8 to 15 eggs is what we should be aiming for, but not all patients are capable of achieving that number. Some have low egg reserves, are older and will get lower egg numbers, and some we can't avoid getting large egg numbers because of their characteristics, being younger, having large ovaries full of eggs, such as polycystic ovarian syndrome. The final take-home message is, don't get too hung up over the exact number of eggs you have, because at the end of the day, it's not the egg that is going to achieve your baby, it's the embryo. So if you have, for example, 5 eggs but get 4 embryos, you are 4 times better off than a patient who gets 50 eggs and only has 1 embryo. So remember, it's the number of embryos, not the number of eggs. Thank you for listening to the channel. I hope that you found the information of value. If you have, please feel free to share it with friends who might also benefit from the information, and subscribe to the channel. This is the first in a series of podcasts that I'm going to perform, and each one of them will address a very particular issue in IVF, a very specific question. Thank you for listening.